Good afternoon, dear audience, dear committee. Let me introduce my PhD topic in mobile motion analysis. My name is Azamat Bissenov. I am second-year PhD student in Department of Orthopedics. My vision is high-quality health change behavior in the personalized medical care for disabled people. To persuade of this vision, my mission is to promote widespread use of mobile motion analysis system for easier diagnosis and the more accurate treatment of musculoskeletal disorders. There are two specific goals related to my PhD topic. My first topic is titled Investigating the Validity of Inertial Measurement Unit on Gait Parameters in Ambulatory Individuals. The gait, the way of walking, is complex motor functions that involve coordination of multiple body systems. And the impairment of gait is particularly common in several diseases, such as osteoarthritis, cerebral palsy, and stroke survivors. Currently, the gold standard to assess gait parameters is 3D motion analysis system, which is known for its accuracy and reliability, but usually characterized by high costs and technical complexities. Nowadays, the alternative system to assess gait parameters is called inertial measurement units, which is cost-effective and portable, which make it more accessible for a wider range of population. My aim to evaluate the validity of EMU for motion tracking. In this picture, you can clearly see this both system. 3D motion analysis system requires specialized place with experienced staff who can perform and analyze data. By inertial measurement units, you can assess gait parameters by using some sensors and a mobile phone. From this, my clinical question arises. Does EMU have clinically acceptable validity in measuring gait parameters? Our population is ambulatory individuals. We focused on data from EMU compared with gold standard 3D motion analysis system, our diagnosis of interest, gait parameters. Our hypothesis, EMU technology demonstrates comparable validity in capturing gait parameters. Our systematic search was conducted November 25, 2023 in 4 databases by using these 4 domains. After systematic search, almost 15,000 hits was found. By narrowing it down, 23 full text was chosen for further analysis. I want to introduce a little bit our outcome measure. Our outcome measure root mean square error, which usually used in biomechanical studies. It shows difference between gold standard and the alternative system. If difference is high, root mean square error will be high, which indicates less accuracy. If difference is low, root mean square error also will be low, which indicates better accuracy. So by using this outcome measure, we focused in 3 main joints where we used during the walking. This is ankle, knee, and the hip joints. So our first results for ankle joint angle during the walking outcome measure root mean square error, which may range from 0 until infinity. We divided our way of walking for 2 subgroups: overground walking and the treadmill walking. Pulled root mean square error for overground walking 4.15, for treadmill walking pulled root mean square error 5.46. Overall, from both conditions, pulled root mean square error 4.62, which is under the acceptable threshold 5. Our second outcome was similar outcome measure, but for second joint, for knee joint range of motion, pulled root mean square error for overground walking 4.81, for treadmill walking 5.90, overall pulled root mean square error 4.93, which is also under the acceptable threshold. Our third outcome for hip joint with similar outcome measure, pulled root mean square error for overground walking 5.08, for treadmill walking 6.94, but overall root mean square error 5.79, which is out of reasonable limit. So in conclusion, I can say the EMU-based gait analysis system have clinical acceptable validity compared with 3D motion analysis system for knee joint, for ankle joint, In practice, it allows to use this system where 3D motion analysis system unaffordable. Also, it allows clinicians to use this system out of laboratory condition. But implication for research, this system should be evaluated because root mean square error for hip joint out of reasonable limit. So currently our first topic finished and submitted for Gait in the Pasteur Journal. Our second topic is titled Evaluating the Validity and the Reliability of Inertial Measurement Units for Balance Assessment. Balance is crucial for everyday activities in the mobility. It's often compromised in the musculoskeletal and the neurological condition. Impairment of balance leads to millions of fractures, especially in older adults over the 65 years old. 1 of 3 individuals experience at least 1 falls each year. This statistical highlights importance of early diagnose and implement prevention for balance impairment. So currently, balance is assessed by using force plate in specialized labs. However, inertial measurement units can offer a more cost-effective and a portable alternative. So aim of this study to assess validity and the reliability of EIMU for balance assessment. In this you can see this both system, as I showed previously. Force plate requires specialized lab. EIMU you can assess by sensors. So from this, our clinical question comes up: how valid and reliable are EIMU in assessing balance compared to force plate? Our population is also ambulatory individuals. Index test EIMU, reference test gold standard force plate. We specifically focused in several balance parameters like length, area, range, mean velocity, and the total power. Our hypothesis, EIMU measurements will be reliable and have clinically acceptable validity compared to force plate. Implication for research in the clinic, we want to improve balance assessment tools and improve accessibility for balance assessment tools. So our systematic search was conducted October 7, 2024 by using these 2 domains. Almost 13,000 hits was found by narrowing it down. 21 full text was chosen for further analysis. So this is progress from our second project. We finished our data analysis and I have some preliminary results from my second project. So our outcome measure is correlation coefficient for validity and the interclass correlation for reliability between 2 balance assessment tools. And balance was assessed under the eyes open and the eyes closed condition. We focus this the main balance measurements, and today I will show my results for pulse length and the SWOI area. So SWOI pulse length is total distance of body movement while trying to stay balanced, and the SWOI area is area covered by these movements. So our first result is SWOI area under the eyes open condition. Outcome measure correlation coefficient. So pooled correlation coefficient between both EIMU and the force plate is 0.8, which indicates strong relationship between these both systems. Our second outcome also similar like my first one, but under the eyes closed condition with similar outcome measure correlation coefficient, pooled correlation coefficient 0.82, which also indicates strong relationship between these systems. Second outcome, my pulse length, total distance of movement try to stay balanced under the eyes open condition, pooled correlation coefficient 0.75, also indicates strong correlation. It's under the eyes closed condition for pulse length, also with similar outcome measure, pooled correlation coefficient 0.85, which also indicates a strong correlation. So in summary, my first project is finished, we submitted, and we are working on this. My second project I'm planning to finish in July 2025. So my additional activities, I have teaching activities in school. I presented my first project in orthopedic seminar in Salzburg, also sport activities. I represent Semmelweis University in Hungarian Judo Championship. We got second place. I want to finish my presentation with Hippocrates thought, walking is man's best medicine. Thank you for your attention.
My first question, okay, I can start. Just this is translational medicine, and you prefer to translate your results for the practice. And what do you think about it? What about your main results which can be converted to practice?
Yes, thank you for your question. So from my results, we can use this EAMU system for rehabilitation in orthopedics fields to assess range of motion in patients, especially if patients couldn't come to hospital. We can track progress individually at home by using these sensors. Also, it's a cheaper alternative. 3D laboratory, it's unaffordable everywhere, but this system is 100 times cheaper than this lab. Also, it will be good alternative to use in orthopedic, in neurology, in several fields.
Yes, IMU, we can accept IMU. This is a valid system, right?
Yes, it shows it's valid.
Yes. Is this convertible to the sports sciences? What do you think about it?
Yes, it's currently it's mostly used in sports science to assess acceleration and athletes' performance.
Thank you for your presentation. I just want to ask why you include, like you did separate analysis for open eye and closed eye conditions?
Okay, thank you for your question. We investigated balance under the eyes open and eyes closed condition because when people eyes open, we assess visual input to stay balanced. When eyes closed, we assess a vestibular system and the proprioception system to assess balance, to say from which side we have balance impairment, from which system.
So the gait patterns, what are you using that to identify? Is it to identify people who need surgery, people who are fall risks, people who have had surgery and their recovery? Where would you use that in the clinic? Where would you give a patient the sensors on the mobile phone app?
Thank you for your question. So we can use this system to indication for operation to assess range of motion. We can use for this in orthopedics fields. Also, we can track rehabilitation after the surgery to say range of motion after the surgery, because after the surgery, people usually have a contracture of joint. So we can assess by the time by using this system. Also, for foot drop in neurological condition, we can track progress, range of motion of joint by using this system. Especially for joints, it's good in sports fields, as I said previously, to assess athletes' performance. We are using a good way to assess performance, especially in cerebral palsy. It's using mostly currently the Gait lab to assess contracture and the other muscle system.
And as a decision-making tool, you know, do you have thresholds that say, right, if you're below this or above this, then you need surgery, or if you're above or below this, you haven't had a proper post-operative recovery? What's the decision-making piece on it?
I say this threshold is 5 degrees to make inaccuracy. I showed previously in RMC. It's 5 because until 5 degrees inaccuracy doesn't affect our decision. That's why it's 5 degrees. If it's out of 5, it may cause inaccuracy in decision making. That's why we use the threshold 5. So it will show us about this range of motion to make this decision and to progress treatment plan.
So that's the accuracy of the tool, but then does that also map onto, you know, if you've got osteoarthritis of your hip, there's a decision point that you need surgery. Do you have those worked out?
It's not also range of motion. Also in osteoarthritis, we assess by X-ray, but it will be like supplementary to assess patient's joint, but not only for this to make decision.
Sorry, I'm working at the same place as Azamat, and I am making the clinical validity of the AMU and 3D analysis. And in Vienna, in the 3D Gait lab, they can specialize which joint, which contracture is the problem about the kinetic and kinematics data. And the plan is that we make a validity between the AMU and the 3D Gait lab. And after that, we can use the AMU so special than in Vienna, the 3D Gait lab. So this is the plan, but we are in the start period. So first of all, we have to validity in the clinical field, and after that, when we have a threshold that this is a standard, after that we can use for the rehabilitation, for the pre-op and post-op data. So, this is a future plan now.
Early days. Thank you. Do you have any other? Yeah, we do.
Can we go back to your first study?
Mm-hmm.
So what always makes me wonder is that that huge difference between those studies.
Mm-hmm. Thank you.
Almost an order of magnitude.
Yes, thank you for your question. Yes, heterogeneity.
I haven't asked yet.
Yes, heterogeneity is high because different models of EAMU was used, different models and different rates. They have rates like the power of EAMU, also location of EAMU, and the calibration process affect how you collaborate. These tools before you use how you calibrate to show proper results. Also, to derive these results, we calculate from acceleration and the angular velocity, and the calculation methods also affect results. Because from 3D Gait lab, you can immediately take results for range of motion, but from EAMU, you have to indirectly calculate this outcome. This also affects this heterogeneity because of this reason, several reasons: location, calibration, and the calculation methods.
Thank you for your presentation. It was quite interesting for me as well. As one of the teachers mentioned, it's translational medicine. So how do you think, would it be regarding the costs an option to translate it into a general healthcare unit? What are the costs for maintaining such a system?
The cost, it's much cheaper than 3D motion analysis system. Like I told before, it's almost 100 times less than that system. That's why we are promoting to use this system, because in healthcare system in the world is not the same. It will be a good option for some countries. For example, I'm from Kazakhstan. In Kazakhstan, we don't have any Gait lab. It will be a good alternative for us to use in everyday practice.
Okay, thank you for your answer.
So I would like to start by congratulating you on the very nice presentation, and particularly the timing. You got it perfectly. I think you were like 5 seconds left towards the end, and it was perfectly, timed throughout. So my question, I mean, there isn't much anymore to ask after everyone has asked their questions. So I would like to maybe address a couple of presentational points.
Mm-hmm.
One of those is in your forest plot.
Mm-hmm.
Maybe you can show it, but so it is customary to, in forest plots, to order the studies in so chronologically, mm-hmm. in the order as they were published. So from the most, from the oldest studies gradually to the newest
mm-hmm.
studies. So obviously you didn't do that here. You ordered them differently. I was wondering how you decided that.
Yeah, because it was because of mean difference from low to high. It was ordered in this
attestation. Yes, but is this something that your mentor asked you to do, or you decided yourself based on maybe some literature, or?
No any point to do like this. It was done by help of statistician, and it was ordered in this based on mean difference. That's why.
Okay, so I'm not
Yes,
sure.
but we can yes, order from based on year.
I'm not sure what other members of the committee think, but my belief is that they should be ordered chronologically, and that actually helps with assessment of all these different measures, how they developed historically. Not measures, sorry, but estimates. So, and then your answer also sort of asked, directed me towards another question. You had a help of the statistician, I hear.
Yes.
Did you also have a help from a librarian for doing your search?
From library, if you don't have full text, we can request from library for full text.
No,
Yeah,
but
no.
I mean for creating search strings for your systematic reviews.
We usually do it by help of our SMS, our supervisor. We create our search key.
Okay. Okay, so are you aware of the reporting guideline for systematic reviews? From Equator Network, which one would it be?
Guideline for systematic referred.
For reporting of systematic reviews and
It's
meta-analysis.
Prisma guidelines,
Yes, exactly.
Prisma.
So are you aware of the items there?
Yes, preferred report items for systematic review. But search key, it cannot be included, yes, for Prisma guidelines.
Okay, so it is recommended that you include
No,
a
don't
librarian?
include.
Sorry?
Don't include for this one?
No. It
Include.
is recommended
Yes,
that you do. No, I was just wondering whether you did it or not. And then my last question, it's methodological. So for screening of the articles, I'm not sure whether you have done them already or not. Screening all those thousands of articles that you showed us that were results of your search. Did you screen them already?
Yes, we screened all.
So I was wondering whether this was done independently in duplicate, by whom, and were there any discrepancies?
We did with our co-investigator. We did our text selection with our co-investigator in Ryan website. It's Ryan AI. We did in that website blinded our full text in the full text selection.
And discrepancies? How were they
It was
resolved?
solved with third investigator. It was solved with third investigator in our project.
Can you tell us a ballpark number of those discrepancies?
Well, it has 0.9, 0.97. Cohen's kappa you were asking about? Yes.
There are several stages, I see, but okay, quite high. Okay, thanks very much.